super honored to have you here.
Thanks, brother.
Yeah, man.
Wow. Oh, man. I'm pretty sure that's way more credit than I've ever earned or deserved, and I'm really humbled to be here. So first of all, just thank you for having me, and thank you all to everybody who showed up today. So I guess I'll start with the bottom line up front. A career in military special operations, it's inevitable that with the high intensity, high training nature of the work, that there's a massive dose of cumulative allostatic load, and I'll come back and define that a little bit, but it affects all of the human physiological systems. And I think that's a really important point to understand, is that what we're talking about here is physiological. I'm not really, here to talk about necessarily about all the woo-woo psychological stuff without acknowledging the importance of the physiological. Operator syndrome is not a medical diagnosis. It's a framework to understand the constellation of very common interrelated injuries, and I think Glenn really said it nicely. These things all get intermingled. You damage one part of one system, and that has ripple effects on every other system, which then in turn ripple back. Think of operator syndrome as a guide to soft performance, if we think of it earlier in a career, and as a way is a framework for developing treatment approaches for later in a career, in both. And I want to say, I know a lot of you are military, and I also know a lot of you are first responders, law enforcement, and firefighters. I just put this slide deck together last week, and I realized after I got here, I forgot to add a couple of slides related to first responders. So I guess at the outset, I want to say a little bit, when I talk about operator, I'm using the term a little bit loosely. I want to include, and we'll get into this, in the nature of the injuries, the nature of the experiences and the exposures. It's not just operators, and a lot of my work is with law enforcement and firefighters. Let me just a few words about my background, and this is not intended to be a humble brag or anything like that, but just to give you a context of where I come from. So I have a PhD in clinical psychology. I spent the first 15 years of my career, roughly speaking, in the US VA system as a clinician, also as a researcher. So I had the grants, VA grants, DoD grants, NIH grants, probably over 325 scientific papers. So I really come from an empirical place in my career. I left VA in 2006 with a lot of frustration. Loved the guys I worked with, the gals I worked with, loved the clinicians around me, but I couldn't abide the system. Stuff coming from the top to me was just tragically broken. And we don't even need to get into all of that, but I thought my work with veterans was mostly over at that time. I went to the University of Hawaii, where I am today. Also along the way, since I've been in Hawaii, I've been director of research programs at Baylor College of Medicine, and then UT, University of Texas Medical School in Houston, hired me to set up a center for veterans. So that's my background. About a decade ago, so this is now part of the story that I think helps maybe set the context for what we're going to talk about today. My friend network in Houston were veterans, and most of them came from the SOF community. One of my close friends, or became a close friend, was a former SEAL Team 6 DevGru SEAL who'd been on a lot of the famous missions and whatnot. And he had a complaint, and his friend said, "You ought to talk to Chris, because he's an expert in PTSD. He's an expert in PTSD." So we had a cup of coffee, we sat down, what's going on, okay? And what he described to me is what I hear now every time I have a first conversation with an operator or a responder. And that complaint or that representation is something is wrong with me, but I don't know what. I'm confused, I'm lost, nothing seems to be working as it used to, but I don't know how to make sense of it, and neither do my my care providers. And so I'm thinking, I got you, this is probably PTSD, we'll get this taken care of. It was not PTSD. He didn't have the cardinal features of fear reactivity. He wasn't avoiding things that would have reminded him of his military service. And then for that was like a wake-up call for me, and it became a trial and error thing. Like, what the hell is going on here? We got a blood panel, metabolic panel. We got another blood panel looking at hormones, and it was just like, what? This guy had the testosterone of an 80-year-old man, a 90-year-old man. He was 37. He had just left the Navy. He had just separated the year before. At 37, his testosterone was under 100. That didn't make any sense to me at the time. We got a sleep study, he has sleep apnea. That also didn't make any sense to me at the time. Now it makes sense because I see it over and over and over and over again. So since that time, about 10 years ago to today, fast forward today, I've probably talked with about 600 operators over the years across all of the US branches, Canada, some other countries. I work individually with people who are out of the military, and I work with people who are still active duty. And in the last 3 or 4 years, I've been doing more work with responders, first responders, firefighters, and law enforcement. And here's maybe a piece of the story that I think that is important to acknowledge. I don't work for the VA anymore. I never worked for the Department of Defense. I've never served. I've never been in any uniform of any sort, other than the suit and tie, monkey suit that we have to wear in medical schools. So people could talk with me, and I'm not part of their chain of command. And so I think that has kind of opened the door. I could talk with Glenn, and he could have confidence that our conversations weren't going anywhere. All right, I promised to define allostatic load. I'm just going to read this. And I'll try not to do too much reading, although I have a couple of slides I'm just going to read. So allostatic load, it's a hypothetical way of understanding physiological strain. Okay, so quote, the strain on the body produced by repeated ups and downs of physiologic response, as well as by the elevated activity of physiologic systems under challenge and the changes in metabolism and the impact of wear and tear on a number of organs and tissues, which can predispose the organism to disease. I know that's highfalutin. Just to break it down, this just is a way of saying it's all the burden, all the stress, everything that comes onto us physiologically. And what's not in this, it should be, maybe I should put it in the title, but it's cumulative. It adds up over time. The things that damage and injure you today and tomorrow and next week and next month, they add up. And so we're looking at the effects on all of our systems, the nervous system, the endocrine system, immune system, metabolic system, musculoskeletal, respiratory, perceptual, cardiovascular systems, et cetera, and then the social systems. So our marriages, our families, our units, the community around us, our employers, et cetera. So the way I frame operator syndrome is that it's the natural consequence. It's not a weakness, as Glenn said, it's inevitable. It's a natural consequence of an extraordinarily high allostatic load. And this includes a whole lot of different things, but if you have a career in special forces, if you have a lengthy career in firefighting, law enforcement, you're going to be at risk for these things. And I want to just acknowledge the causative factors, and this is not even a complete list. Not everything on here is relevant to everybody, but these are the factors. So blast exposures, certainly for military, also for many folks in the responder community. Just to say a word, the next point on that list is impact forces, which is something we're probably all familiar with. A blow to the head, a punch, a fall, something that smacks us on the head can cause a concussion. And that's a bruise to the brain, and the more concussions we rack up over time, we run the risk of what's now known as chronic traumatic encephalopathy. And that is marked by a gradual, slow buildup of tau proteins, Tau. tau proteins in the brain. Unfortunately, we can only find that on postmortem. So you got to be dead for us to be able to see that. Blast exposures, we are now learning. The first time I ever learned about this was in a paper that was published in 2016, so 8 years ago. Blast exposures have a different signature injury in the brain. They damage and scar the glial cells, which are the scaffolding of our neurons. We have 10 glial cells to every neuron, roughly speaking. So we have a billion neurons, and we have, I guess, 10 billion glial cells, if my math is correct, which it often isn't. But the damage to the glial cells shows up also on postmortem in a scarring pattern. And it's been named interface astroglial scarring. So even given a separate name. So what we're appreciating is that blast exposures have a shearing effect that goes through all the soft tissue, and it damages the brain in a way that's different from impact forces. All right, nothing on this list is going to be a surprise to you folks, but I'll run through much of this quickly. The high op tempo and the chronic stress. Yes, sir.
Did you see the blast exposure through wet lung hour or other?
No, we can't see the blast exposures through our current technology for neuroimaging. PET scans, MRI don't show it. I mean, we can get a little bit of clinically relevant data if there's a large lesion or a tumor, but these are very difficult to diagnose. And the way we're doing it with people who are alive is through taking a very comprehensive history of, were you a breacher, did you fire shoulder fire rockets, were you ever blown up, and just getting an extensive history of exposures. For me, and I think it's pretty clear from the data, that if you passed selection and spent any time in a soft unit, you by definition have enough blast exposures just inherent in the job to have some TBI, some traumatic brain injury. Naval Special Warfare, their data that they kind of hold close to the vest, but their data shows that in the 2 years of training before a new SEAL gets to their first platoon, the TBI rate is about 95%. So we just have to assume it's there unless we can come up with a reason to say otherwise. Thank you, good question. And by the way, questions are welcome as we go. And in fact, do we have any kind of time limitation or constraint? I don't want to bore you guys for too long, so I'll try to keep.
Sensible openers at 7, so we're good.
I will probably fall over myself well before then. Okay, so that high op tempo, that chronic stress means you never get a chance to reset. You're never coming down. Cortisol and other stress hormones are always activated. Sleep deprivation, bad enough, but then you add the circadian disruption. You're working at night, you're traveling across time zones frequently. You're not keeping normal banker's hours, and you're not keeping normal sleep hours. One of the things the sleep experts will tell you is going to bed at the same time and getting up at the same time is a really important aspect of sleep health, and that becomes impossible with these kind of jobs. Toxic exposures, inevitable. Rucking, diving, jumping out of perfectly good airplanes, rappelling, combatives. I mean, how many times have you been choked out? Ask yourself that question. Tactical driving with whiplash effects and things like that. All of these things have prominent effects on every part of our system. Our joints, our brain, everything else. Then we get into some things like violence and death, loss of teammates, the constant high intensity training, orthopedic injuries. You know, it's not uncommon for me to talk to guys with 8 to 12 orthopedic surgeries. A good friend of mine, a retired SEAL a few years ago, died after routine knee surgery. He had a blood clot and he passed away. It was his 22nd orthopedic surgery. It was supposed to be routine. Nobody thought it was going to be a big deal, but guess what? You're rolling the dice every single time you have a surgery. Then we have the time away from home, the missed milestones, the holidays, the missed anniversaries, all of those things. The length of the career. I don't know any operators or responders that only serve for 2 years or only serve for 4 years. And I say only, but we're looking at folks that do 10 years, 15 years, 25 years, sometimes more. And then the culture, the never quit culture, which you have to have. We can't change that. That's critical to mission success, right? But it means guys are pushing through injuries and they're not raising their hand. They're not taking that pause, that time out. They're not getting the care along the way that they need because they don't want to be pulled off the line. All right, so this is, right here is the framework. This is the operator syndrome. When people say, what is operator syndrome? These are the interrelated injuries. Starting with traumatic brain injury, which, as I just said, is 95% just from 2 years of the first 2 years of SEAL training. Quite sure it's the same for every other branch and flavor of operators. And traumatic brain injury itself brings a cascade of issues, some of which are, many of which are also listed here. So sleep disturbance, insomnia, but also apnea. Why do guys have sleep apnea? We're not sure. Probably a combination of the traumatic brain injury, as well as maybe the circadian disruptions and just the long-term chronic stress and sleep problems. Hormone dysfunction. Every guy I know, every guy I've worked with, low-hanging fruit is get your hormones tested every few years. If you're 22, get them tested anyway. You're probably not going to have low testosterone, but get a baseline. See where they are. Every guy I know over 30 either has diagnosed low testosterone or testosterone that's very at the low end of what medicine calls the normal range. And by the way, the normal range is general population. So it's not operators, responders aren't being compared to their own baseline from their own early years. They're being compared to Gen Pop, which may not be a fair comparison at all. Certainly depression, anxiety, PTSD, hypervigilance, addiction, alcohol abuse in particular. It's so cultural. It's ubiquitous, it's universal. In a lot of units, alcohol drinking is a competitive sport within a unit, and so that culture is undeniable. And unfortunately, alcohol. I'm not a teetotaler myself, but alcohol is a fragments the sleep, so it makes sleep worse. It's bad for our brains, so it makes TBI worse. It affects our hormones. The addiction itself, the high alcohol use itself, becomes part of the ongoing damage that we do. We see perceptual impairments to all of the perceptual systems, especially hearing, vision, and balance. Impaired balance is a symptom of TBI. It's a very common symptom, but it's often an overlooked symptom. When I talk with guys, I'm asking, are you as agile as you used to be? How's your hand-eye coordination? Are you clumsier than you used to be? Do you drop things? I've talked with guys that describe bruises on their shoulders from, stumbling into door frames and things like that. Hand up?
No.
Okay. Cognitive impairments, also related to depression, anxiety, insomnia, but also related to TBI. We know that to be an operator, the average IQ of operators is north of 85 percentile. So we're talking about guys that are highly intelligent, creative problem solvers, and yet by early 30s we see problems with concentration, especially sustained concentration, multitasking, short-term memory, staying organized, and learning of new skills and talents is impaired. So now you talk about, we haven't even gotten to the transition issues, but when you transition out of the service or out of your departments as a responder into something else, learning new skills, learning new language, learning how to fit into a new culture is a challenge. What's the divorce rate? 150%? 250%? marriages get crushed. Operator syndrome hammers the spouse. Spouses are lonely. Spouses are managing a lot of things on their own, managing the whole family. They're functioning as single parents much or most of the time. Operator comes home from a deployment or home from a training evolution. A responder comes home at the end of the day. It's not necessarily a really happy reunion moment, typically. That's a stressful point in time itself. Most civilians think of, oh yeah, you see the movies, they get the plane lands and the wives and children are waiting on the flight line and there's these hugs and happiness and it's, hooray. It's usually not that easy of a happy moment. And then we have intimacy concerns that are sexual, but worse than sexual concerns are the emotional intimacy difficulties. I'll talk a little bit in a few minutes about the loss of empathy or the lack of empathy that develops in responders and operators and combatants. That's a pretty normal and natural extension of the experiences. And empathy in a war zone isn't going to help you. Empathy out on the streets is not adaptive necessarily. But how do you flip it on and off when you're home versus working? And that's a huge challenge. And one of the things I always try to do when I'm working with an individual operator or responder is to involve the spouse as much as possible. Get the spouse involved, help them learn, help them be educated, help them start to understand so that they can have those conversations. Toxic exposures, respiratory illnesses, cancers, other kinds of autoimmune disorders, we're seeing pretty high rates. I don't think we've got a full understanding of this yet, certainly. And then the existential concerns, which I want to just talk about here for a moment. I am not saying that there is no PTSD. I don't want you to hear that message coming from me. But I don't think PTSD is the signature injury or problem that you all are experiencing. It may be a piece of it. It's hard to separate. One of the questions I've had for a long time, and other psychologists, psychiatrists, is have we medicalized human suffering? Have we over-medicalized human suffering? How do you think anybody could go to war or go into the streets as a warrior, as a protector, without being affected at a human level? And why do we have to call that a psychiatric illness? I don't think we do. I think we can recognize that the way it changes us as people is significant, and to be able to talk about it and acknowledge it. So this is a list of just kind of my list of things. I have a book, I have a chapter in the book on each of these, short paragraphs on each of these. But I'll start with the horror of killing. And this is what civilians assume, that a lot of the existential angst is the horror of what you've seen, what you've done, what you've been forced into in terms of situations, and the horror of taking a human life. What doesn't get acknowledged, what doesn't get talked about often is the thrill of killing, the enjoyment, the exhilaration of it, which Hemingway had an amazing quote in one of his short stories in the mid-30s. I'll just paraphrase it, but once a man has hunted other men, nothing else can ever come close. Nothing else can compare to that in terms of bringing oneself to feel alive. Most guys I talk to about this specific topic and I will ask about it. And I will ask in moments that are completely private, where there's no, any risk of anybody else knowing or hearing about it. But a lot of guys will say to me, thank you for asking that. Nobody's ever asked me that question before. Wow. And it isn't just, it was thrilling and I miss it and I'd go do it again if I could. It's also, I feel terrible for feeling this way. I feel guilty because I liked it. I feel guilty because I miss it. And nobody can know that. That can't be in my children's thoughts. That can't be in my spouse's thoughts. Totally understand that. Other things, impossible choices. You go left, somebody's going to die. You go right, somebody's going to die. There's no clear, perfect choice. Choices often are impossible. Loss, grief, rage, survivor's guilt, moral injury, shame. We can put a lot of different names to it, and it takes a lot of different flavors. Guarantee pretty much everybody in this room who's done the work can, probably a 30-minute conversation, we could find some specific moments or specific events. Just maybe some examples. Somebody who was otherwise supposed to be on extortion, 17, and maybe got pulled off that bird at the last minute, and somebody else put on that bird. It was shot down, everybody killed in action, and now you're living with the idea that somebody was in your seat, somebody took your spot. That's a dramatic example. It's a real example. The loss of empathy. I have this myself. I've never put on a uniform. I've never gone downrange. I teach college students. I teach undergraduate college classes. And when they talk about what's stressful to them, I have to bite my tongue. What they think of as stressful to me, and I can put myself into a point of compassion with them and go, yes, that is stressful. Your dog died, or the homework was hard, or you're struggling with your dating life, whatever. But in comparison to what you guys have seen and done and been a part of, it's hard. It's often hard to have empathy for the daily stressors and problems that most of us civilians struggle with. End of service experiences. I don't really know very many operators who ended their career on a happy note. It's always hard. And you could look at NHL or NFL, very few people go out on a happy note there. But in the military, I was at a retirement ceremony for a friend of mine in Virginia Beach 6 or 7 years ago. And I was standing in the reception afterwards. I was talking with some guys. I said, "You probably come to these things all the time, right?" And they were like, "No, it's very rare. Most guys just leave. They're med boarded out. They're reassigned. They go on some kind of other end of career duty service. A lot of times there's an unhappy reason why they're being pushed somewhere else." So a lot of people, when they're done with their career, suddenly it's over. They're no longer part of the tribe, they no longer have that mission and purpose, and they got a bad taste in their mouth. I just don't know many people who have looked back on the very end of their career and felt good about it. As Gordo said, childhood trauma and adversity, very high rates of that. That's another thing that kind of surprised me early on, was how many people in the SOF community, how many people in the law enforcement community have childhood trauma, childhood adversity. Sometimes it's physical, sexual abuse, sometimes it's emotional abuse, sometimes it's neglect, but it's there and it's significant. And then we have betrayal of nation and society. And this kind of goes to the end of service experiences. We pulled out of Afghanistan in a way that was pretty shameful. What was it all about? We forced a vaccine mandate on soldiers. In a way that was punitive and coercive, and now we kind of have the data to know it was a mistake to mandate it the way we did. We have the diversity, equity, inclusion issues in many places, where meritocracy is maybe not being valued or honored in the same way it used to be. And then when you've gone through all of this, where's your humanity? What's your faith like? And that's a hard conversation for a lot of guys. Just pause for questions, comments. Okay. We wrote a paper in 2020, medical paper in the Journal of International Medicine and Psychiatry. This is an image that we drew up for that paper. And I just cut and pasted it into this PowerPoint slide. I realize you guys can't really see this very, very meaningful or digest it, but I just wanted to kind of flash it up here. By the way, this paper, the paper we published in 2020, is titled Operator Syndrome. I'm the lead author. You can find it on the internet. If you just Google Operator Syndrome paper, it should come up right up. And it's on a lot of foundation websites now. You can get a PDF, and it's an easy read. It's a descriptive paper. It basically covers a lot of what I'm talking about today, although now I know a lot more on the treatment side of things. Okay, as Gordo said, suicide no bueno. In the book that I wrote, and by the way, this is a short book, it's a practical guide. I wrote it for operators and their families, their spouses. It's not a book written for people with MDs or PhDs or social work degrees or our nursing degrees. It's written for operators and responders. Throughout the book, I have quotes from people that I know and have worked with over the years. And most of them have names. This is an anonymous quote, but it encapsulates the issue. So this is a former Marine Corps recon and a former private defense contractor. Quote is, "I've had 7 buddies eat a bullet after coming home." I hear that all the time. Sometimes it's 5, sometimes it's 10 friends, sometimes it's more than that. Since I've been working in the community, pretty much once a month, somebody I know sends me a text saying, "Oh, my friend so-and-so just took their life last night." That is not uncommon. I did a podcast with David Rutherford, a former SEAL and contractor, for Black Rifle Coffee earlier this year. And he read off a list of his friends, and I think there were about 12 names. And then I added a few other names, not of people I knew personally, but of names of people that I've had awareness of. We're seeing very high rates of suicide, which is an unfortunate downstream effect of operator syndrome when it's not treated. And I want to make an emphasis now that I'll come back and say there's hope. So that's the important thing. The only other quote I want to read from my book, because I think it's powerful, and this is the top quote in chapter 1. And this comes from a soldier named Clay Jensen. He was at 7th Group, and he was a contractor, did a lot of kind of ground branch work in Afghanistan. Here's his quote. And this illustrates a point I hear a lot. In fact, I think Glenn said it himself from his perspective. Every time I see a new primary doctor, VA or civilian, they are completely overwhelmed by the sheer number and severity of the different medical issues I have. Nobody knows how to treat me. I'm completely different from any other patient they've had. For over 10 years, I struggled to understand why I am the way I am and to know what was really wrong with me. Then I came across an article on operator syndrome, and I was like, quote, "Holy shit, I'm normal." I went from feeling totally alone to being part of the tribe again. Why aren't we getting people the right care? Why aren't we getting people the care they need? And I have some ideas. This is not a comprehensive list, but I think it helps to be aware of there are obstacles that you guys are facing. And you're not surprised to hear me say that, but let's just kind of let's put some language to some of these obstacles. And let's acknowledge that it's not necessarily the fault of any one individual. These are systemic issues. PTSD is way overdiagnosed. We've come to use it as the easy button. You're an officer involved shooting, hit that red easy button, PTSD. You come back from a deployment and you're not feeling good or you're not functioning well, PTSD is the easy button. I did it myself for a long time. I did it with that first SEAL I was working with. I made that as an assumption. Mental health care, we have our blind spots. We don't know enough about TBI. We don't know enough about hormones. We don't think about hormones. Guess what? If you have low testosterone, it looks like major depressive disorder in a man. You're going to have insomnia. You're going to have irritability, low motivation, poor concentration. You're going to feel just not yourself. And if we treat that with an SSRI or we treat that with psychotherapy for depression, might help a little bit, but probably not going to be hitting the root causes of what's really needed. We also have healthcare systems that are fragmented by specialties. You go over here for a sleep doc, you go over here for a pain doc, you go over here for a GI doc. They're not talking to each other. They're not comparing notes. In theory, yes, they should have an awareness because they should have an electronic medical record that they can look at and see. But without those integrated conversations, none of us are getting the best high quality care that we could be getting with more integration. And that's especially a problem when you talk about having more than one problem. Operator syndrome is complex. The best programs out there, and there are a few, at least in the US, that are trying to do this better, bring operators in and they get a multidisciplinary team that works with them, where that team actually sits and has conversations together about each of their patients. We're still learning about TBI. Like I said, we didn't even know what blast exposures meant until relatively recently. We have terrible cultural competence on how to work with operators and responders. And by that I mean, here's an example. A friend of mine, former Marine Raider, and then in one of the other tier units working with intelligence, he went out and got a PhD in clinical psychology and got a job at the VA. And every week he has cultural competence training that's required by the VA. Every week it's something on racial trauma, LGBTQ trauma, gender trauma. He's never had any cultural competence training related to veterans. The US VA doesn't even think about veterans or military culture or war or combat now. And I know there's some clinicians in the audience today, and I'm pretty sure you are the ones with cultural competence if you're here and you're learning. But how does a soldier or a law enforcement or a firefighter walk in and talk to a therapist who has a lot of assumptions that are not actually well grounded in reality? And we're not doing enough on prevention in health. So again, operator syndrome is a framework. You can think of it as a way to optimize performance and extend career longevity. I have a friend who retired from DevGru a few years ago, and his 19-year-old son is now prepping to go to BUD/S. He wants to follow in his father's footsteps. They're using this book. His father's in the book with a quote, but they're using the book with the son. He's using his book with his son as a way of helping prepare him not just to get through BUD/S and do well, but to thrive for what they both hope will be a long, multi-decade career. And then it's also a framework to guide the treatment of injuries and impairments. So some implications. These are my thoughts. Physiology should be forward. Right now in traditional mental health care, we have kind of the emotional piece forward with physiology way in the background. I'm not saying the emotions aren't important, they certainly are, but we need to do more of pushing the physiology forward. And we've gone way astray by labeling every problem as PTSD. We need to be more comprehensive and integrated and multidisciplinary in how we're managing both lifestyle habits and treatments. All right, so let me go back. Those are my implications. Now I want to say some good news, because we have a lot of things we can do. And I'll divide this into lifestyle habits, and then I'll talk about treatments. The good thing about lifestyle habits, it's within you, it's on you, it's within your control. You control the way you run your life up to a point. So I think it starts with sleep, prioritizing your sleep, doing the best you can to schedule as much and regular sleep as you can and build that into your routine as much as possible. Get a sleep study, find out what sleep disorders you might have. It might be apnea, it might be restless leg syndrome, which is pretty common too. And it sounds like, oh, big deal, your legs move a little bit in your sleep. No, it's when your legs are kicking, it's waking you up, even if you don't know it. So you get into REM or a slow wave sleep, and those leg movements pop you out of it, even if you don't have a conscious awareness of it. Sleep hygiene, this almost sounds silly or trivial, but when we really look at how most of us sleep, we're not using good habits. We have our phones next to us in bed. We have a TV running. Maybe our bedroom isn't dark enough, isn't cool enough, isn't quiet enough. And there's other things. Our bedtime routine matters. It's really important. And these are just skills that you can learn. ICBT is a very common program. There's a SEAL who's developed something called 62 Romeo. Great sleep programs. No medications involved. The other major lifestyle habit that I put a focus on is, in part because it encompasses kind of everything, is to live an anti-inflammatory life. Now, we all know what inflammation is. It's an immune response. You cut yourself, you get a paper cut, it's going to turn red, it's going to get a little swollen, it's going to feel hot to the touch even. That's our bodies activating its immune system to defend and help that wound heal, protect it from being infected. So we need it. However, we don't live the way our ancestors lived. We don't live a lifestyle now that's harmonious with the way we have evolved over tens of thousands of years. So what we're seeing now is an inflammatory response that's throughout our entire bodies, in every cell in our body, circulating in our bloodstream. And we can measure this inflammation with blood markers, with CT scans. But essentially, we're now learning that inflammation at the systemic level is chronic, and it's driving. It's a causative factor in pretty much every chronic disease in modern lifestyle. Cancers, metabolic disorders and obesity, heart diseases, depression. Depression is often caused by, or at least a major cause of depression is inflammation in the bloodstream. So anything you can do to bring that inflammation down is going to be good for you. And also, a TBI involves neuroinflammation. Our neurons get inflamed. So what are we going to do about it? Well, don't hate me, but you need to eat a whole food diet with sufficient protein. You need to eliminate or at least minimize all the crap you're eating. Soda, fast food, junk food, sugar, added sugars. Anything that's highly processed is an inflammatory. Consider supplementing, and you can do your own reading. I don't want to be too prescriptive here, but omega-3s, vitamin D, turmeric, magnesium, there's a number of dietary supplements that really can help bring the inflammation down. Intermittent fasting, to eat on an 8 or 9 hour schedule or less, but even 8 or 9 hours is really powerful for helping reduce inflammation and manage weight. Minimizing alcohol and tobacco, regular exercise, and then recovery practices. There are now randomized controlled medical trials of hot sauna bathing, showing that it's an effective treatment for depression, that it effectively lowers inflammation in the body. This is now something we know medically. Medical science is now showing this. So, get the government to pay for a hot sauna in your house if you don't already have one. Is that something ONE9 can fund for everybody? Cold plunging, meditation, journalizing, positive social experiences are all really important. All right, I just have a few more slides left, and these are the treatments. So I want to acknowledge traditional mental health care treatments. This is what I've been a part of for 32 years now. Psychotherapy is very valuable. I encourage psychotherapy. However, it's not going to address everything, and it isn't going to help at all if your therapist is a dipshit who doesn't know anything about your life, the work, the kinds of things you've been doing, the kinds of things you've been exposed to. A story that I've heard probably 30 times over the years is an operator or a responder walks in for a first appointment with a social worker or a psychologist, and within 15 minutes, the psychologist is on the floor crying when they hear about the horrible experiences that are being, that the soldier is talking about. They're not prepared. They're shocked. They're caught off guard. There just is not that understanding. Everything they think they know, they probably got from a movie, Hollywood. Psychiatric medications. almost inevitable that if you go to traditional mental health care, at least certainly in the US, you're going to be prescribed an antidepressant, an SSRI usually, but then maybe medication to help sleep, stimulants to help get you going in the morning, or help you focus, anxiolytic medications, painkillers, erectile dysfunction medications. And then these cause side effects, so then sometimes there's more medications to help manage side effects. I shit you not, I know guys commonly in the US, at least from the VA, have been prescribed 20 medications, 20 different medications. I was once at a meeting, we went around the table, a group of veterans, and it was, yeah, I was on 18, I was on 20, I was on 22, I was on 12. I guess I got away with, got it easy. And every one of them guys said what I knew they would say, which was when they brought it down to 1 or 2 or none, they felt better, they functioned better. So we are grossly over-medicating in modern medicine. Now, we have a lot of treatments that we are not widely using. Some of these treatments are relatively new, as in the last 10 years. Some of these treatments are now becoming more and more widely used as people learn about them. But let me just go through these. Again, for me, the low-hanging fruit is get a sleep study, get your hormones evaluated. If you have hormonal dysregulation of testosterone, thyroid, human growth hormone, estrogen being elevated in men, estrogen being low in females, drop very precipitously low in females, these are treatable. They're not necessarily, having low T does not mean you need to take exogenous testosterone necessarily. Might be what you need, but it might not be. There's a variety of ways of addressing it. And when you address it, like with this first seal that I talked about from 10 years ago, who by the way is still a good friend of mine, game changer. Going from low testosterone to healthy testosterone, right there, his life was radically changed. His functioning became different. And it's not all about sexual functioning. People misread that. They think it's about sexual functioning and getting jacked. And that's why there's so much resistance in the medical systems to treating it. We need to be more mindful of addressing this and paying attention to it. Treatments C and D are two treatments I recommend frequently. Stellate ganglion block is a treatment that I almost think we ought to just set up clinics on base. Clinics next door to fire stations and police departments. How many of you have heard of stellate ganglion block? Good. A lot of hands going up, but maybe half. So that means half of you haven't. Let me tell you what stellate ganglion block is. Stellate ganglion block is a short procedure. It's outpatient. You guys are usually in and out in 45 minutes or so. It works virtually immediately, as in later that same day or the next day. And what it does is it brings the baseline physiological arousal from an 8 or a 9 baseline, and it just brings it down to a 3 or a 4 for most people. It's a very fast way to reset your sympathetic nervous system. That's what it is. It involves receiving an injection into the stellate ganglion, which is part of the fight or flight sympathetic nervous system. They access it in the side of the neck, around C6, C7, and it's just an injection. Sometimes it's lidocaine or novocaine. Some people use other medications. It's not even a new treatment. Neurologists have been using it for 100 years, since the 1920s. That's how low tech it is. We didn't really know the full benefits of it until about a decade ago. There was a former SEAL who got an MD, became a neurologist, and he noticed that when he treated soldiers for their headaches with stellate ganglion, and that's how it was used as a treatment for cluster headaches and other kinds of head and neck pain, he noticed that they would come back on a follow-up and report that they felt more calm, more relaxed. Their spouses liked them again because they weren't jerks. They were sleeping better. The anger came way down. man, why are we not offering this? In the US, I only know of one VA in the whole country. There's probably more, but I only know of one that provides it. And you got to jump through 20 hoops to get it. It's not even expensive. But who provides it? It's not mental health care providers. It's not me, it's not psychologists, it's not psychiatrists, it's neurologists, sometimes anesthesiologists. So it's a treatment that doesn't exist within traditional mental health care. So when people are diagnosed with PTSD, they're too often not even aware that this treatment is out there. Not only does it help with the anxiety, the physiological arousal, but we now have a hypothesis and some signal data, some early data, indicating that it probably also helps heal the brain. It's a TBI intervention as well, we think. And research is being done now to test that hypothesis, to look at that. Wow. We really need to be, for me, this is a no-brainer because it's safe. The only side effect is for about 3 hours, you look like you just had a stroke, facial drooping on the side, and that goes away. Now, there is one limitation that's important to acknowledge. It's not a cure, it doesn't last forever, but it's a reset. Some people get 2 months of benefit, some people get 6, some people get 12, and we're seeing some people getting longer. And I think we're improving the quality of the treatment. Some people get dual-sided. Dr. Lipoff in Chicago is now doing double on one side and hitting once on the other side and seeing really long-lasting relief. It creates an opportunity. It opens a window of time to be relaxed, to reconnect, to reset, to start sleeping better, to start changing other lifestyle habits. And it's a beautiful way to do that and then get into therapy because now you're at a different place. And so those conversations with a therapist can be very different. As a therapist, and I don't do any traditional, counseling or therapy now. I think of myself more as a coach, and this is the curriculum I'm coaching people on, so to speak. But it's a terrific, it's one of the very first things I say to people because it's low-hanging fruit. Well, let's get this done today or tomorrow, and then that will have a beneficial effect on everything in your life, and it will help us do some of these other things. All right, ketamine infusions. I am a fan of ketamine infusions, and I emphasize the word infusions. I'm not a fan of, something you found in the back alley. Don't do that. I'm not a fan of the programs that will send it to you at your home or the nasal inhalers. I think some of that stuff is not very necessarily safe, but maybe worse, not very effective. But 4 sessions, maybe 6, maybe 8 sessions at a ketamine clinic where you're sitting in a chair and they drip it into your bloodstream intravenously is a powerful antidepressant, anti-anxiolytic intervention. You're usually in the chair for about an hour and then they disconnect and you sit there for another hour or so until your head clears and then you're done for the day. Lipoff and I just published a paper a few months ago, small paper, case study, but his idea is to use stellate and ketamine in the same week. So at his clinics, you get 4 ketamine treatments in a week. You're there for 5 days, you get all the stellate and 4 or 5 ketamine treatments in that week. So compressed, and it's really powerful. We think the stellate and the ketamine are symbiotic in that they elevate each other. And there's separate data that suggests ketamine, like stellate ganglion block, also helps stimulate neurogenerativity, helps stimulate the growth of new neurons and development of dendrites and new connections and wiring of pathways. So stellate ganglion and ketamine may be good treatments for TBI as well as anxiety. A few other things here. Vestibular therapies. Vestibular therapy is essentially physical therapy for your inner ear, for your equilibrium. One example of it is you get strapped into a chair that slowly moves in different 3-dimensional ways, tilts you over to one side, tilts you backwards, tilts you over. And what it's doing is it's reorienting the little particles in the inner ear. Powerful benefit to people with vertigo, powerful benefit to people with TBI-related disequilibrium. I see a lot of vertigo and disequilibrium in operators. Vertigo symptoms are a combination of problems with balance combined with nauseousness, maybe vomiting. And my own wife did her own version of vestibular therapy. She watched a YouTube video. She used to have a lot of vertigo. She watched the Bob and Brad video series, and what she does when she gets her vertigo, which she almost never does anymore, but she sits on the side of the bed and she does the rotational movements herself without the chair, just sitting on her bed. So I have not ever provided this treatment myself, obviously, but it seems to be very powerful for folks. Okay, we now have something called transcranial magnetic stimulation, which is an approved treatment for depression. It involves about 30 sessions of sitting in a chair while a little bit of low dose magnetic stimulation is just kind of buzzed into one side of the head and it goes back and forth, hence the name transcranial. It's a relatively gentle, it's not a shock treatment. People watch TV or read a magazine while they're reading it. And now there's a proprietary company that's developed a way of improving the precision for this with EEG readings, and that's now known as magnetic electronic resonance therapy. And I'm not a part of that company, but I've worked with their data, and I'm helping write up some of this data because they're almost exclusively using it with SOF operators. And now the US Air Force is using this with active duty operators, their PJs and combat controllers, and they're using it they're using it to treat people with specific symptoms of TBI and anxiety, but they're also now using it prophylactically with people who are early and mid-career on a regular periodic basis with the intent, and this is, I guess, a hypothesis, but the intent of can it improve cognitive functioning in active soldiers, and can it extend the length of career functioning? And I think there's a lot of hope there. You can kind of see where we're going with this. As Gordo said at the outset, if one thing doesn't work for you, we got a kitchen sink. We got a lot of things that are worth looking into, learning about, and trying. Right now, 4 years ago, I got Heroic Hearts reached out to me and wanted me to work with them, and I was just like, no, thank you. Psychedelics, that's nonsense. I was a true skeptic. I've come full circle. Now I work a little bit with Heroic Hearts and the Mission Within and Vets, Inc. I believe psychedelics will be mainstream healthcare. The benefits of these interventions for treating existential issues, the psychiatric issues, the traumatic brain injuries. A recent study that was published by researchers at Stanford earlier this year, they took essentially what we call a chart review study. They took a stack of about 100 records of operators who went through an ibogaine treatment journey, and they looked at not just how did they do on the psychiatric issues, but did their TBI symptoms get better? And yes, they got excuse me. They got wildly better. Not just a little bit better, but wildly better. One of the programs down in Mexico, because it's not legal in the U.S., it's not approved in the U.S. I think it's maybe Canada's a little bit ahead of where the U.S. is, from what I've come to understand. But in the U.S., guys are going down to Mexico, and one of the programs there does ibogaine on the first night and 5-MeO-DMT on the second night. So it's essentially it's a 2-night treatment program. The ibogaine is kind of kicks your ass. It's a 8 to 12 hour journey for a lot of people, and it often involves vomiting and all kinds of purging and emotional stuff, and it's not easy. It's not like, hey, I'm gonna go. It's not like having an easy cocktail. People recover the next day, and then the second night they do the 5-MeO-DMT, and that's usually more like an hour, 45-minute journey. So it's kind of quick, but it's also powerful. And the theory is that they enhance each other. That doing them together, that they're symbiotic. The doctor, Martin Polanco, who runs one of the clinics, he has a organization called the Mission Within. This has been legal in Mexico for decades. So he's now in the US working almost exclusively with responders and operators. But for 17 years, he ran a clinic in Mexico that was just a mainstream clinic for addiction. And so this is not new medicine. This is something that has been used medically and carefully and thoughtfully. Now, I'll come to you in just a moment. I want to emphasize, again, I'm not a fan of, getting some Jim Bros, from his bag, some mushrooms that he grew in his basement. I know that people do that. Now, I'm not a fan of that. You need to be careful with that. I'm not a fan of microdosing because we don't know what that means or what that is. Microdosing is anything people want it to mean. There are risks to psychedelic medicines. It wouldn't be powerful if there wasn't also a risk. Anything that works on our nervous system that has the power to help us also has the power to affect us in ways that aren't good. Having your blood pressure monitored, getting a cardiac screening, I think is important and it matters, and that's the benefit of doing it in a medical clinic type thing. All right, you had a question.
Can you try these treatments if you're under SSRI, any other antidepressant?
The answer is yes. I know many people who do. The other answer is we don't really know what's the best or most optimal way to use them. So I would say we are in the infancy of doing good, rigorous medical research with these compounds. How do we make the best use of them? How do we best dose them? How do we best combine them with other mainstream medications or interventions? These are all things it's going to take time to figure out. What I will say is these are not psychedelics are not like magic pills. You don't just go, to the clinic, get it done, and then go home and woohoo and go on with your life. They really work best when you've taken time to, the different phrases, but I would say, integration therapy or having a therapy that goes along with it, clearing your schedule for a week or two ahead of time to really spend some time thinking about what you want to get out of it and what you're doing, and then having time afterwards. The guys that go to Mexico and do it, then they go to San Diego and are drinking, cocktails in the airport before they fly home. That's not, they're kind of unwinding, they're undoing the benefits, and they're not getting the most out of it. So I think you do need to be thoughtful. You do need to be very mindful and deliberate about what you're doing, and it's best to do it with an integrative or therapeutic approach. And that could be a standard traditional psychotherapy. It doesn't have to be anything kind of magical. I do have a friend who wrote a book about his own journey, and it's a very short read. You can find it on Kindle. He put it up there for free, so there's no cost. You can get it, an e-version of it on Kindle, about how he made the best use of his own integrative approaches. The author's name is Joe Schmuckatelli, which obviously not his actual name, but it's a name that I guess in the US military at least means something to people. Joe Schmuckatelli. Hyperbaric oxygen therapy. This is interesting. 5 years ago, the science on this, some people said the science was settled, that it did not help with psychiatric disorders and it did not help with TBI. There were 2 or 3 clinical trials that really showed not great benefits. And so a lot of people just stopped there. Our Israeli colleagues didn't stop there. They've continued to do the research, and their protocol, the Israeli protocol, now just published within the last 2 years, a series of studies show really nice benefits for using hyperbaric oxygen therapy. One of the things they did was they increased the number of sessions, and they did different levels of pressurization in the dive tanks. But what they found is HBOT can be an effective treatment for anxiety and PTSD, even without the presence of TBI. And when people have TBI, that also benefits from the HBOT. Now, problem with HBOT therapy is it's time consuming. The Israeli protocol, I think, is now 60 sessions. You can do 2 a day, but each session is 90 minutes. So that means spending 3 hours a day sitting in a tank. And you can read, you can do things. You're not just sitting there, but that means quite a commitment of time to do that. Functional medicine approaches. And this is something I'm learning about. I don't know a whole lot about this, but through the SEAL Future Foundation work that I do, they've been sending a lot of SEALs now to functional medicine clinics where they're using stem cells, NAD+ infusions, and other things, both to treat joint pain, chronic pain in the joints, as well as TBI. And we're seeing really good effects, really good benefits. So I don't know what the state of functional medicine in Canada is, but that's something else for us to be looking into and learning about. Last thing I'll say here, and there's probably there's probably some other treatments, peer support. I work with a number of different foundations in the US, probably 8 or 9 different foundations. The one that has the most innovative and what I see as effective is the SEAL Future Foundation. You can Google them, and they have a whole page on operator health that's public information. Anybody can look at that. We developed that with a medical advisory board, which I chair, and we've put this thing together. But the way their program works is if a retired SEAL calls the number, they're going to talk to another SEAL. They're going to talk to a brother who was a medic. And it's going to be a conversation. It's not a medical conversation, but it's an advisory consultation. And then they're given advice, they're given options. SEAL Future then has a large network that will provide, they know where to refer people to all of these things, and they'll pay for it then. Now it works, in the US, it works for SEALs, I think, because they're a small community. There's only about 15,000 SEALs alive. And so with a $3 million budget, they're able to help everybody that's coming in the door. I think last year it was about 2,500 SEALs came in. And what we're seeing is the first year it was like 500, the next year it was 1,000, last year it was 2,500, and we're running out of money now because it's looking like it'll be more like 4,000 or 5,000 this year. But for 2 or 3 million a year, a foundation can provide a very robust program to help operators or responders. CanSoft is not that big, so maybe that's something for folks in this room to start thinking about in terms of solutions going forward. And I'm going to end on just a couple of points here. Operator syndrome is treatable. As I said, I've worked with hundreds of guys. As far as I can tell and know, and I don't just mean one conversations, I mean I often have weekly conversations over 6 months or a year or even longer. I've not lost anybody to suicide that I know of, and I've seen over and over and over and over again individuals and families find incredible levels of healing and recovery and wellness in their lives. So I know firsthand from what I have seen that there can be enduring, lasting, wonderful benefits and quality of life improvements. So there's hope. Now, you have to be mindful of the barriers and you have to be mindful of the obstacles, but if you get educated, you can go and you can begin to do some things that will help you and help your family. One strategy that I often recommend is get the operator syndrome paper, print it off, sit down with it with a highlighter and kind of start marking it up, some of the things that are relevant to you. Then take that to your primary provider, your primary care provider, and share it with them, show it to them. Educate your providers, because nobody's coming to save you. You guys are going to have to save yourselves, and you are. I'm seeing it. But that also includes educating your own providers and asking for what you need, demanding for what you need. I do have a book, and apologies for trying to advertise it here. I have a generic treatment plan in the book. I have kind of a step-by-step suggestions on how to kind of strategically and tactically move forward with finding your care. So education and persistence and problem solving, and that's what you guys are great at. That's what you guys are known for. Bring it to yourself, bring it to your families. Just a few recommended readings here. Really good paper. I don't think you're able to read this, but a really good paper at the bottom written by 2 Army officers who took a year off and did a program at Harvard Kennedy School titled Modern Warfare Destroys Brains. The 2016 paper I mentioned on blast exposures is right there. That's an interesting paper, and then a couple of my things. And I just want to thank you guys, and I'll be happy to stick around. I'll be happy to take questions, comments, discussion.